Good afternoon, Chairpersons Professor Narasimhan and Professor Amin, distinguished speakers from abroad, distinguished speakers from India, my dear colleagues and friends. At the outset, I want to thank Dr. Krishnamurthy for this kind invitation to speak at the Indo-UK workshop on elder care. And I would dwell upon the epidemiology, the pathophysiology, the treatment available, and everything depends on efficacy and safety. One shouldn't offset the other one. And I also want to give two catchwords: pragmatism and what is ideal. Because we have to be rational. We cannot be irrational in treating elderly with hypertension. Okay, so the question is, a meta-analysis of 31 hypertensive trials involving 190,000 patients who had a mean age of 65 years reported that all classes of drugs were equally successful and the risk reduction was proportional to the reduction in systolic BP. So we need to work on this platform. And despite preference given to thiazide diuretics, which were shown to reduce the mortality in previous outcome trials as first-line therapy primarily on the basis of JNC 7 recommendation, debate continues regarding the role of alternative classes in the elderly. The leading global risk for mortality in the world are high blood pressure, responsible for 13% of the deaths globally, tobacco use in 9%, high blood glucose in 6%, physical inactivity in 6%, and overweight and obesity in 5%. What is geriatric hypertension? Majority of the people, 2/3 of the people older than 60 years of age, I have also crossed that, have high BP. Mainly of the isolated systolic hypertension. Hypertension is defined by a systolic BP of 140 or more millimeters of mercury, diastolic BP of 90 millimeters or more, independent of the age. Efficacy of antihypertensive treatment seems to be diminishing with age. Not more than 25% of the elderly patients with hypertension have controlled BP levels. Hypertensive gene or genetic study have shown some concordance between genetic effects of BP with age. Systemic BP should be persistently elevated on at least 3 different occasions to diagnose hypertension, basic premise. What is the cause of hypertension when you see an elderly? Specifically, is there a potentially reversible form of secondary hypertension? Is there evidence of target organ damage? Are there coexistent cardiovascular risk factors? Now, when we teach our medical students to check the blood pressure, I do not know how we teach them, but this is taken from George Barkey's textbook, which shows that the feet should be flat when the blood pressure is being checked. If the feet is in a hyperextensive position, you will have isometric contraction and increase the blood pressure, and the arm should be laying on the side, and the patient should be resting on the rest. You shouldn't be sitting forward, which can increase the blood pressure, systolic blood pressure, by about 6 to 7 millimeters of mercury. Mechanisms. What are the mechanisms? Do we know everything about hypertension? I said that 2/3 of the people will have high blood pressure. Abnormalities in the regulatory functions of the vascular endothelium, overproduction of vasoconstrictor prostaglandins, progressive decline of nitric oxide, we all know that it's a vasodilator in the vessel walls, decrease in elastic arterial compliance, especially in the aorta and the major blood vessels, because I will show you the picture later on. Aortic, systolic and pulse pressure rise progressively and linearly with age. Increased systolic BP and pulse pressure are strong risk factors for cardiovascular morbidity and mortality in elderly than elevated diastolic blood pressure. Reduced salt taste perception. A lot of the people, even I think that I am also getting the same thing after the age of 60. So we need more salt to perceive that we are eating salt. And this will also contribute indirectly to the high blood pressure. Now, I want you to look at this figure. This shows the aorta of a young person, young elastic vessels. During systole, you can see that it distends, and diastole it contracts. And when you look at an old elastic vessel, you can see that, it is not compliant, it just remains as a steel tube, both systole and diastole. And when you look at the pulse wave velocity, you can also see in this that there is increased systolic and there is increased pulse wave velocity in this, in the lower one. Increased pulse wave velocity, and as you can see that this pulse wave velocity is dependent on the arterioles and then on the stiffness of the aorta, and which will lead to left ventricular hypertrophy. So an increased pulse wave velocity is an important risk factor for cardiovascular morbidity and mortality, including left ventricular hypertrophy, diastolic dysfunction, congestive cardiac failure, and stroke. So the percentage of population with high BP, if you look at the horizontal axis, you can see the ages, both men and women. The dark one is men and the light one are the women. And you can see that as the percentage population, as you age, you have a very high prevalence of hypertension both in males and females. When you look at this particular data, what percentage of Indian population have a controlled blood pressure or blood pressure of less than 140/90? Only 9% of the hypertensive population. And when you look at this graph, bar graph, this shows what in 2000, the countries where you have high blood pressure and what is predicted in 2025. As you can see that the bars sizes are increasing. So the QS study, which was published by Dr. Mohan and his colleagues from Chennai, QR stands for Chennai Urban and Rural Study, showed that with an advancing age, there is an increase in the blood pressure both in males and females. And it is not alien to us that even in Chennai, we have people, as they age, nearly 50 to 55 to 60% have high blood pressure. And when you look at the changes in the systolic blood pressure and pulse pressure, and this is the pressure, the systolic blood pressure, and this is the pulse pressure, and this shows the age, you can see that in multiple studies by Nicholas and a few other colleagues, it has shown that even from China, unfortunately we don't have data from India. Even though we have 1.2 million population and many people are working on that, we don't have published data on this. See, there is a progressive rise in systolic blood pressure, you can see that, and also in the pulse pressure, which are two important determinants of cardiovascular morbidity and mortality. And when you look at this cartoon, you can see on this side there is a square, and on the other side the square is missing. And when you look at this dotted lines, above that the risk increases to about 100% as it reaches top, and this is normal. And you look at the red line, which shows the arterial stiffness 40th year, and as it goes on, cardiovascular events, you have seen the orange and it goes to the red, showing that there is a progressive increase in cardiovascular events, and there is a progressive increase in aortic stiffness as you age, and leading to a risk score which is going higher. Hypertension, diabetes mellitus, and lipids may fluctuate despite the increase in the arterial stiffness, as shown here, glycemic, the lipids, and the mean arterial pressure. So when you look at the autoregulation, we all studied physiology in the Ganong, that autoregulation is a very important part of cerebral circulation. And when you look at that, with rightward shift in hypertension, you can see it here. This is the mean arterial pressure from 0 to 150. So you can see the physiological one here. And when it exceeds this or goes below that, you are not able to maintain the autoregulation. And in hypertensives, there is a rightward shift in this autoregulation. And when you have a stroke, the whole thing is gone. So it has been very clearly shown in one of the elderly studies, those with blood pressure, systolic blood pressure above 187 millimeters of mercury following a hemorrhagic stroke, if the blood pressure was lowered, systolic blood pressure was lowered by 27 millimeters of mercury, surgery, within the first 8 hours, there was a 6-fold increase in adverse outcomes in those between 70 to 76 years. And from 76 to 80, there was a 10-fold increase in adverse events. And those who are above the age of 80, there was a 15-fold increase in adverse outcome. So you need to keep very closely that when you have a stroke, and especially a hemorrhagic stroke, the blood pressure lowering has to be very carefully done so that you don't produce more impairment and more problems for the patient. The usefulness of ambulatory blood pressure. This was the thesis of one of my students in Ramachandra when I was studying there. And it shows a dipper and a non-dipper. See, you can see the dipper here. Early morning there is a dipping. And here you can see a non-dipper. And the dipper has less cardiovascular events compared to a non-dipper. And the dipping should not be more than 20 millimeters of mercury. If it is more than that, you have more adverse events. Now, how blood pressure impacts kidney disease? Because it is a silent killer, chronic kidney disease. I am going to dwell on that also in a few slides. Treatment, primary prevention. That is, primary prevention is not to produce damage to the kidney. Treatment of high blood pressure would be directed to primary prevention of end organ damage, such as chronic kidney disease. What is secondary prevention? You have already a creatinine of 1.7 or 1.8 or 2. You have chronic kidney disease stage 2 or stage 3, depending upon your body surface area. Management of hypertension in CKD for secondary prevention to minimize the velocity of kidney function decline and the attendant cardiovascular risk. Now, when you look at this, look at the different quartiles, quartile 1, quartile 2, quartile 3, and factors affecting GFR with aging. 2,100 men, and you can see that the systolic hypertension in the elderly, the most important thing is systolic blood pressure, followed by mean arterial blood pressure, pulse pressure, and the least important is the diastolic blood pressure. Now, secondary blood pressure. This was one of my patients who came with a creatinine of 5 milligram, and when we looked at that, we found that she had, if you can see the abdominal aorta is severely diseased there, and the right and the left renal arteries are not obviously seen, suggesting renovascular hypertension due to atherosclerotic disease. So clinical features: age of onset hypertension below the age of 30, above the age of 55, abrupt onset of severe hypertension, hypertension resistant to medication therapy, target organ damage such as fundi with acute hemorrhage and exudates. It is important to mention, being an MD examiner and an MRCP examination, we are not included fundus examination as a part of our MD examination, and very few of our students know how to look at a fundus, whereas in an MRCP examination it is a part and parcel of the MRCP examination. So fundi with acute hemorrhages and exudate, renal dysfunction, left ventricular hypertrophy. Features indicative of secondary hypertension are unprovoked hypokalemia, abdominal bruit or of diffuse atherosclerosis, ACE inhibitor therapy producing increased renal dysfunction, labile hypertension, sweats, tremor, headache suggesting pheochromocytoma, family history of renal disease, and palpable polycystic kidneys. Kidney disease in a hypertension. This was a lady, 82-year-old, well, vibrant lady who had she's not diabetic, who had a coronary intervention done in 2009, and she had a creatinine of 1.2 at that time. So for a 82-year-old lady with a 1.2 creatinine is slightly high. When we looked at that, she came with a creatinine of 1.9. So I wanted to look at that. So the question is it hypertensive disease or is it something else? So anyhow, when we looked at the CT, we found that right kidney is small and there is no bruit, nothing at all, and she has mild hypertension being controlled with calcium channel blockers, and the left kidney is normal in size. So there is no significant proteinuria, so we are worried. So what did we find? This highlights the importance of renal biopsy even in elderly. We are bringing up a whole set of 800 slides for the International Society of Nephrology, and it highlights the fact that even in elderly, you need renal biopsies. So what did it show? it showed acute pyelonephritis. If you look at that, you can see a lot of neutrophilic infiltrate, CAS with WBCs there, and you can see that. And so it is a treatable condition. It is not due to hypertension, and she was given appropriate antibiotics, antimicrobials, and her creatinine has come down to 1.4 now over a period of 3 weeks. I would like to recall, I was asked to write an editorial in the Oxford Journal on pyelonephritis. All medical students should read that. It just came out on the internet. A review written on diagnosis of pyelonephritis in people. Now, this is another gentleman. He was 77-year-old hypertensive, came with renal dysfunction and with minimal proteinuria, decided to do a biopsy. If you look at that, this is a strip, and you can see that the glomeruli are sclerosed, suggesting an end-stage kidney disease. And we could tell the family that he is progressing and he has hypertension. Hypertension control is necessary for secondary prevention. And for the last 5 years, he is on dialysis, doing reasonably well. Now, global diabetic prevalence by age and gender in 2000, estimated number with diabetes by group 2000 to 2030. When you look at the age group, you can see that there is a sharp rise both in males and females as they get old in diabetes. And this is the age group in 2000 and 2030 predicted. You can see that there will be a progressive increase in the prevalence of diabetes as in 2030. And diabetes is usually associated with hypertension in a large percentage of patients. And who are these diabetics? They are elderly, as we discussed. Hypertension prevalence in type 2 diabetes, in the microalbuminuria stage, it is about 40 to 80. Proteinuria reduction by ACE-ARB is effective. GFR progression less effective in the microalbuminuria stage. Whereas in the macroalbuminuria stage, hypertension is seen in 70 to 90%. Proteinuria reduction is seen with ACE-ARB, and GFR progression very effective by using ACE-ARB. Now, this is the Chronic Kidney Disease Registry of India. This is available to anybody if you go to this website, and this is already published. We are a part of that. When we looked at the people, a large percentage segment of people with chronic kidney disease in India had age between 61 to over 70. And when we looked at the hypertension, depending upon the stage, you can see that stage 1, stage 2, stage 3, there is a progressive increase in hypertension, suggesting that the older people with chronic kidney disease, they have more hypertension. So when we looked at the number of drugs used on the left-hand side, 0 to 4, you can see stage 1, stage 2, stage 3, stage 5. You can see that drug use increases, and ACE-ARBs are used in stage 1 in 27%, and in stage 5, why this reduction? There is always a fear that it will lead to hyperkalemia and the patient may die. Now, when we looked at the cardiovascular disease in CKD, results of multiple logistic regression analysis, hypertension stood out as one of the significant factors. You can see the p-value there. So, arterial stiffness with advancing age is an independent predictor of cardiovascular events. Carotid femoral pulse wave velocity is a measure of intrinsic aortic wall stiffness. Central pressure assessment may improve identification and treatment of patients with increased cardiovascular risk. Do we have any biomarkers either at the tissue level or in the serum level? The tissue biomarkers are the endothelial dysfunction, the stiffness of the blood vessels, and also the carotid femoral pulse wave velocity. And are there any serum markers? And the serum markers we have is, at this point in time, are only highly sensitive CRP and homocysteine, which are of negligible value. Sorry. So in the hypertension treatment of the elderly, high weight, the benefits of treatment became apparent within the first year, and at conclusion were associated with the reduction of stroke, heart failure, and mortality. So guidelines, highlight the need for consistent and smooth 24-hour reduction of BP. Treatment guidelines recommend the use of long-acting once-daily agents that provide sustained 24-hour BP control, as these offer greater protection against cardiovascular events. Optimal treatment of high BP requires strategies that lower BP consistently and fully throughout 24-hour period, maintain normal circadian pattern of BP, and do not increase the BP variable. So the question comes, what sort of drug we use? Is ACE inhibitors can be used, or ARB can be used? Calcium channel diuretic. In the all-heart study, which compared diuretic and with the other drugs, found that diuretics were equally effective along with ACE inhibitors in reducing the cardiovascular events. But at the same time, the advantage was that ACE inhibitors had beneficial effect, although the renin-aldosterone activation was not there in the elderly, they had beneficial effect. Now, when you look at this, you can see that cardiovascular protection drug classes have a different effect on LVH reduction, because left ventricular mass index is one of the markers of left ventricular hypertrophy. You look at diuretics, beta blockers, calcium channel blockade, ACI, and ARB. So ARB stands out. Now, treatment. Antihypertensives in all patients regardless of age, caution in frail and elderly. Higher BP goals appropriate in patients with early dementia. Drugs may predispose elderly to symptomatic, orthostatic, and postprandial hypertension. Benefit in CV outcomes and stroke compared with younger patients. JNC7 BP goal in older patients should be less than 140 by 90 millimeters of mercury, but keep this in mind and keep this in mind. Cochrane database, 15 trials published in 2009, 1 year moderate severe hypertension treatment, reduce all-cause mortality, relative risk by 90% for all-cause mortality, 0.9, and cardiovascular risk by 0.72. So when you look at the treatment further, lifestyle modification, sodium restriction by 1.8 gram of sodium a day, weight loss 10 pounds in those who were overweight, reduced and combined reduced by about 55% more cardiovascular morbidity and mortality. The Canadian study for hypertension, 2005, aerobic exercise, alcohol limitation, sodium restriction, healthy body weight, DASH diet, and stress management all helped in reducing the morbidity and mortality. RAS blockade, renin-angiotensin blockade, may become less effective with aging. Renin and aldosterone concentration generally are reduced at rest. But when you rise up or when you are salt depleted, they get activated. So you can theoretically definitely use ACE inhibitors or ARBs. All had thiazide diuretics superior to ACI. In the Australian-New Zealand study, ACI with diuretic, BP reduction similar in both. ARBs in the live study, we showed that, which was cardiovascular reduction was 25% with losartan. In the value trial, valsartan versus amlodipine, morbidity and mortality did not differ. Now, in the post-hoc analysis of renal results, the effectiveness of R therapy extended to the oldest tertile above 65 years of age, in whom doubling of serum creatinine was reduced by 38% and ESRD by 50% with losartan, with no increase in the important adverse effects. So, always a question is being asked by my colleagues, how do you monitor the ACE-ARB therapy? This is a recommendation which came in American Journal of Kidney Disease. You look at the systolic BP, GFR, early GFR decline, and serum potassium. In the first part, you can see that it should be monitored 4 to 12 weeks, and on the second part, it should be monitored in less than 14 weeks. After blood pressure is at goal and dose is stable, 6 to 12 months in the first group and 1 to 6 months in the second group. Now, treatment continued. Adverse event rates lower with R versus ACIs. Beta blockers no longer monotherapy for hypertension alone, but if there is cardiac failure or cardiac ischemic heart disease, this is definitely used along with other drugs. Most elderly patients will require combination therapy because in the number of trials it has been shown that 3/4 required multiple drugs in addition to ACE or ARB. All antihypertensive predispose elderly to symptomatic orthostatic hypotension, postprandial hypotension, syncope and falling episodes. Adherence to medication is compromised. And how do we handle that? This was a Canadian study. We showed that. Standardized medication education to the elderly, regular follow-up, then medication dispensed in time-specific pack to improve the adherence. Because elderly, they are retired, they may not have money, so they may not adhere to that. Now, this is results of hypertension treatment in patients aged over 80 from the hypertension in the elderly study. You have number of slides. Follow-up here is 4. And when you look at the fatal or non-fatal stroke, this is the placebo group and this is the active treatment group. It is not statistically significant, but there is a trend in the difference, the p-value being 0.06. And when you look at the death from any cause, you can see that the p-value is statistically significant in the active treatment group compared to the other group. And when you look at the death from cardiovascular causes, you can see that this is also not 0.06, not statistically significant. And death from stroke, you can see that this is just 0.05. But when you look at the number of events per patient and placebo and active treatment group, it is statistically significant, the p-value being less than 0.001. Now, these are the different effects of antihypertensive treatment on CV outcome in the elderly. 4 major clinical studies. This is the hypertension in the elderly. This is the Swedish study and Eurohypertension. So 4 major studies in elderly, which all shows that mean treatment BP reduction, systolic, diastolic BP, was associated with, you can see the numbers here, significant reduction. Stroke reduction also is significant. Coronary artery disease is also significant, and heart failure reduction. Now, when you look at this slide, treatment efficacy and intensity according to the age and BP control, here it shows the number of maximum doses given, and the different colors shows the age group, 15 to 39, 40 to 49, 50 to 59, 60 to 69, 70 to 79, and more than 80. So when you look at that, in control, the younger people have better control, 80% up to 80% compared to the older, which suggests that either they are not compliant or their blood vessels are very stiff, so it is very difficult to control that. So what are the newer devices for any blood pressure control? Device-guided breathing, biofeedback devices to reduce the sympathetic nervous system activity, bioreflex activation, prolonged carotid sinus nerve stimulation, and this is being increasingly practiced, catheter-based radiofrequency ablation of the renal adrenergic neural system, catheter ablation of 1/4 of the renal arterial circumference. This could reduce the blood pressure up to 2 years. Now, this is the last slide, last but one slide. Adverse events of treatment contribute significantly to non-compliance and non-persistent. The diuretics, the beta blockers, the calcium channel blockers, the ACIs, ARB, so each one has got its own advantages and disadvantages, and one should know everything about that when you treat the elderly, because elderly are more prone to side effects. Now, conclusion. Majority of the people older than 60 years have a high BP, and the prevalence is increasing. Hypertension epidemic. Elderly vascular aging should be a central concept in understanding the individuals who are at increased risk. Physicians are less aggressive about treating older patients with hypertension, despite the fact that they are more likely to have hypertension and benefit from therapy. Thank you for your kind attention.